So yesterday we discussed about all the staphylococcus and streptococcus. So today we are supposed to be starting with your enterococci. Okay. So now before starting with these concepts, I'll be sharing a group of questions today night. Okay. So that is to solve on the basis of staph and strep alone. Okay. So that you guys have a clinical cut of how to go about the question. Okay. So now coming to enterococci. Okay, so first the characteristics of your enterococci. Enterococci, as they have said, it's a gram-positive cocci. So how will a case scenario will be presented to you? Let's say we have a 60-year-old woman. Okay, so now she is coming to the ER because she's been having 6 hours of history of chills and diffuse abdominal pain. So now her complaint is that she is having chills and she is having a diffuse abdominal pain. Okay, so now they're also saying that the patient has had stage renal disease or a history of end stage renal disease which is already present. Okay, so now they're also saying that the patient is on dialysis for the same. The patient is on dialysis for the same approximately 5 times per day, like a peritoneal dialysis. Okay, so now they're also talking about the vitals, like how her temperature is 101 degrees, her pulse is 86 per minute. Okay, so her respiratory rate is 26 per minute, and they're saying the BP is around 112 by 78. Okay, so now symptom wise, this is the case scenario of 60-year-old woman. She's coming to the ER because of a 6 hour history of chills and diffuse abdominal pain, and she's an end stage renal disease, and she is using a peritoneal dialysis 5 times per day. Okay, so now vitals have been mentioned. In the physical examination, the same thing is confirmed, and they're also noticing that in the IV site, the patient is having erythema, that in the IV side, the patient is having erythema. So when we do a microscopic analysis, in the microscopic analysis, what you can see is leukocytosis. What you can see is leukocytosis. Okay, in the microscopic analysis, this leukocytosis, mostly it is neutrophils. Okay, mostly it is neutrophils. So now what they're asking is, they have given you the vitals, they have given you the lab. Okay, so now you have to know what kind of organism it is, what is the characteristic of the organism. Okay, so now here you have to say that because it's a peritoneal dialysis, okay, they are most commonly increasing the risk for catheter associated peritonitis. Okay, so because the patient is on peritoneal dialysis, that will increase your risk for catheter-associated peritonitis. Okay, so that catheter-associated peritonitis is what is causing your abdominal pain. That's what is causing your fever. Okay, so now you should know what is a bacteria, which is a part of a skin, which is the part of your skin flora. Okay, which is the part of your skin flora that is going to be associated with these kind of indwelling medical devices like catheters. Okay, so here I gave a case scenario of yesterday's case discussions. Okay, that was your staphylococcal epidermidis. So here it's staphylococcal epidermidis because yesterday I would have told you the skin flora, normal skin flora. If you want to know a bacteria that is associated with that, that's going to be your staphylococcal epidermidis. Okay, so now the same way we are going to be discussing a case and the concept with respect to your enterococci. Okay, so now, so with respect to enterococci, what all points or what all information I want you guys to remember is that first it's a gram-positive cocci as already they have given. Okay, so now next is the other identification I would say is that it's catalase negative and it is PYR positive. So remember all these three together: gram-positive cocci and catalase negative and PYR positive. So one thing that they can ask a lot of times or given as a clue for your enterococci is a variable hemolysis. Okay, so we saw three types of hemolysis in the differentiation yesterday. So one is a complete, another is partial, another is your no hemolysis, right? So this enterococci is known to have variable hemolysis. Okay, so that variable hemolysis means it can either be an alpha or a gamma hemolysis. Okay, it can either be an alpha or a gamma hemolysis. Okay, so now what we have to remember, apart from the characteristics of gram positive and your catalase negative and your TYR positive, we should know that it is bile resistant. Okay, it is bile resistant because they can give that as a clue as well. Okay, so bile resistant means it can grow in the bile. Okay, and the bile escherichia agar is going to turn into black. Okay, the bile escherichia agar will turn into black. All you have to know is that it can grow in the bile. Okay, and it's going to turn into black. It's bile resistant. Okay, So now next is this can also grow in 6.5% of NaCl. This can also grow in 6.5% of NaCl that is already given here. Okay, so now I want you guys to remember this as characteristic or lab criteria for enterococci, which is going to be given as a clue. So now what are the diseases that you can have with your enterococci? So we have two things that we have to know. One is fecalis, another is specium. Okay, fecal is another is specium. So what is the normal colonic flora? These are the normal colonic flora of the microbiota that you have to remember. So what is the importance is that these both are penicillin G resistant as they have given here. So when a patient is basically having this UTI, the biliary tract infection, subacute endocarditis, okay, so or even your vancomycin resistant enterococci. So now I'll be explaining about these. See, enterococci, they basically have both intrinsic and acquired resistance of antibiotics. So what is intrinsic resistance? Because they are saying that it's penicillin G resistance, right? So they will ask about that more. So what is your intrinsic resistance meaning? So intrinsic resistance, like for example, your beta lactams, for example, your macrolides, for example, your aminoglycosides. Okay, so for example, your trimethoprim sulfamethoxazole, trimethoprim sulfamethoxazole. So these are going to be your intrinsic mechanism as to how why they're having a resistance. Okay, so what is acquired resistance? Acquired resistance is your vancomycin. Acquired resistance is your vancomycin, and that is going to be against your antibiotics. So this is why the enterococci is one of the most important nosocomial pathogen. It's a very important nosocomial pathogen. So now when they talk about these UTI, biliary tract infections, your subacute endocarditis. So we have already discussed subacute endocarditis in a way that if a patient is basically having like a IV catheter, or if a patient is basically having a prosthetic wall. So now if a patient is having a GI or a GU procedure, like a gastrointestinal or a genitourinary procedure, then you have to remember about your enterococci. Okay, like a patient who's having endocarditis. Okay, a patient who's having endocarditis after a cystoscopy. Okay, after a cystoscopy, or a patient who's had endocarditis after a colonoscopy. Okay, or a patient who has had endocarditis after a obstetric procedures. Okay, so some examples I'm just giving you. So these kind of examples I can give you. Okay, so now what is your vancomycin resistant enterococci? So vancomycin resistant enterococci is nothing but they have an altered D-ALA in your cell wall precursors. There is alteration of your DLR. Okay. So that is why the patients are actually having resistance that is acquired. This resistance is either acquired via your plasmids. Okay. It's either acquired via the plasmids or it's acquired via the transposons. Okay. Via the transposons. Okay. So what you have to remember is because of the alteration of the DLR sequence in the cell wall precursors. Okay. So this is going to be, this alteration is by what? By ligases. These alterations are brought to the bacterial protein. Okay, that's because of the ligases. So now the resistance is acquired either via the plasmid, okay, or via the transposon. So when I was teaching about the bacterial genetics, I told you how a plasmid is going to be. So now how do we treat a patient who's already had a vancomycin resistant enterococci? You have to go ahead and give them either three options you have. Okay, so for an enterococci, you have three options. Either you can try linezolid. Anyway, we will discuss in antimicrobials, or you have to try your cyclins, okay, or you have to try your digicycline, or you have to try your streptogramins. Okay, what is streptogramins? For example, I told you, right, the quinupristin and dalfopristin. Okay, the quinupristin and your dalfopristin. So these are called as your streptogramins. Okay, so now this is a content that you have to know about your enterococci. Okay, so now let's move on to the next organism, that is your Bacillus anthrax. Okay, so now with respect to your Bacillus anthracis, okay, which is basically again it's a gram-positive bacteria. Again, it's going to be a toxin-producing bacteria, and it is a spore-forming bacteria. So what are the important points that I want you guys to remember in this paragraph is, because for microbiology you don't have to remember anything extra from the book. Okay, so you just have to remember that it's gram-positive. You have to remember that it's going to be a spore forming rod. Okay, the spore forming the rod, and you have to remember the anthrax toxin, and you have to remember about all the factors put up together, and the medusa head appearance. Okay, so now how they will give you, like in the clue when they're talking about anthrax, we know that it's a organism that they use for bioterrorism. Okay, they use it for bioterrorism. So they will give you this bioterrorism kind of case scenario, and they can tell you that the clue in that is going to be that colonies are having halo of projections. The colonies are having halos of projections. Okay, this kind of presentation can be given to you. So now I think one of your mic is unmute. Can you please check? Yeah. Okay, fine. So I was talking about Bacillus anthrax. It's a gram-positive organism, spore-forming rod, I said, and you have to remember it's a medusa head and the lethal factors. So I will give you a case scenario like how Bacillus anthracis is going to be like presented. Okay. So let's say we have a 37-year-old firefighter. Okay. Let's say we have a 37-year-old, okay, 37-year-old man, and he's a firefighter. Okay, he's coming to the ER and he's saying that he is after responding to the suspected like bioterrorism attack, only he's coming. Okay, there was a bioterrorism attack, and after responding to that, okay, then only he's coming to the ER, and the physical examination is showing a lot of skin sores. The physical examination is showing a lot of skin sores, and that's on the face, that's on the neck, and that's on the arms. Okay, it's on the face, neck, and arms. So now the patient is saying these sores are painless. Okay, these kind of sores are painless. Okay, the patient is saying these sores are painless. So now they're giving you the image of the ulcer. Okay, and the skin sores is the only thing they're giving after the bioterrorism attack. Okay, and the image is showing you this kind of presentation. Okay, the ulcer image is showing you this kind of presentation. So first, what you have to understand, this patient is having an anthrax. Okay, so that is based on the finding that they have a painless necrotic cutaneous ulcer. Okay, because they are having a painless and a necrotic and a cutaneous ulcer. So with that finding only, we can conclude the patient is having a anthrax. Okay, and there is also a overlying eschar on it, and there is also a overlying eschar on it. Okay, so now you can also see the margins are edematous. The margins are edematous here. Okay, this whole part is edematous. Okay, so now this is actually commonly seen in the background of bioterrorism attack. Okay, so now what are the virulence factor of the Bacillus anthracis that you have to remember? The virulence factor is nothing but protective antigen PA, edema factor EF, lethal factor LF. Okay, so now what is important is that this protective antigen and the edema factor, okay, they are going to form the edema toxin. They are going to form the edema toxin. So what is the edema toxin going to do? So now the protective antigen and your edema factor, which is forming your edema toxin, so they are going to convert your ATP. They're going to convert your ATP into intracellular camp. Okay, intracellular camp. So now this camp is going to lead to the activation of your protein kinase A, and now this is going to be, protein kinase A, how this whole mechanism is going to go forward. But what does your lethal factor do? The lethal factor is going to be acting as an endoprotease. This is going to act as an endoprotease. So what is it going to do is that it's going to remove all the N terminus. It's going to remove all the N terminus of all the mitogen activated protein kinases, of all the mitogen activated protein kinases. It's going to remove the N terminus of the MPK, or you can remember mitogen activated protein kinases. So now together with the lethal factor and the edema toxin, both are going to cause necrosis of the cell. Both are going to cause necrosis of the cell, because I told you the finding is basically they're having a painless necrotic cutaneous ulcer. So how is it happening? Because of the protective antigen A, PA, okay, and your edema factor EF, which is forming your edema toxin ET, and that's converting your ATP into intracellular CAMP, that is causing your activation of protein kinase A. Okay, but the lethal factor is acting as an endoprotease, and it's removing the N terminus of the mitogen activated protein kinases. So together, both your lethal factor and the edema toxin, they are causing necrosis of your cells. Okay, so now this kind of mechanism, okay, so you have to remember there are so many other bacteria that is going to be increasing your camp level. So they can ask you what are the other bacteria that is going to increase the camp level. One of such examples I can give you is your Vibrio cholera. Okay, Vibrio cholera is also going to increase your camp level inside the cell, and they're also going to have a similar mechanism. Okay, so this is about your Bacillus anthracis, how a question can be asked. So now what are all the virulence factors and the diseases and the prevention and the treatment you have to know with respect to that is. So now I told you about that is spore, okay, the spore forming rods, right? So now the pulmonary anthrax, if a patient is actually having like a pulmonary anthrax, that is actually because of the inhalation of the spores. Okay, so first I'll discuss about the virulence factors, then I will come to the diseases. So first is that they have a capsule. Okay, the Bacillus anthrax has a capsule, the only bacterium which has a polypeptide capsule. Okay, so this actually contains D-glutamate. This contains D-glutamate instead of a polysaccharide. That is very, very important. It's very unique. The only bacterium which has a polypeptide capsule which contains your D-glutamate, is going to be Bacillus anthrax. So now the anthrax toxin is what I told you. That is your protective antigen is going to translocate both your edema factor. So what is your protective antigen going to do is it's going to take your edema factor and the lethal factor and put it into the cytosol. Put it into the cytosol. Okay. So then what does the lethal factor do? Lethal factor, I told you, it has proteases. It's going to cleave your MAP kinase, and that is going to be releasing all the necessary particles for the necrosis or the black Escher. Okay. So that is a lethal factor. Lethal factor, to put it in a simpler way, you just have to remember that it is a exotoxin and the proteases are going to cleave your MAP kinase. Okay, just that. Okay, this alone you have to remember. And what did I say for edema? Your edema factor. Edema factor, I told you, it's going to act as adenylate cyclase. Because why adenylate cyclase? So that is because it is increasing the CAMP level. It's increasing the CAMP level. The CAMP level is increased means the fluid will enter into the intracellular space. Okay, when it is coming to the intracellular space, you have edema. Okay, so now I want you guys to remember protective antigen is going to translocate both your edema factor and the lethal factor into the cytosol. Okay, lethal factor is a exotoxin. It's going to cleave your MAP kinase, okay, and it's going to be responsible for the necrosis fully. Okay, so now your edema factor is going to be acting as an adenylate cyclase. It's going to increase your CAMP. It's going to cause your fluid to go to the intracellular area, and the patients are going to be having all the defensive mechanism like phagocytosis, the host defenses, everything is going to be inhibited. Okay, so that is your edema factor. Okay, so next what you have to know is how the patient's disease is going to progress. So in a pulmonary anthrax, let's say it is because of the inhalation of the spore. So we call this whole presentation as Wool-Sorter's disease. Okay, it's called as your Wool-Sorter's disease because of the inhalation of the spores. Okay, so now a pre-anthrax of your pulmonary, it's going to spread either via your lymphatics or either via your bloodstream, or you just have to understand that locally also it can just multiply and spread. Okay, so now their presentation is that they always come like a flu-like presentation. Okay, they always come like a flu-like symptom, and they have a very rapid progression of fever. They have a very rapid progression of fever. So now I'm going to be suspecting like why they're having a rapid progression of fever and a flu. Okay, so then I'm also going to be checking if the patient has any pulmonary hemorrhages, and then you can notice that the patients are going to be presenting with pulmonary hemorrhages. Okay, so they are going to be having this hemorrhagic mediastinitis. I want you guys to remember this together. Hemorrhagic mediastinitis. Okay, so what does that meaning is? So in the X-ray, you can see that as a widened mediastinum, as they have told you here. They're going to see as a widened mediastinum. So now this kind of presentation of fever and flu and pulmonary hemorrhage and mediastinitis, okay, and mediastinitis, don't you think this can present as a shock? So this can present as a shock and death. This can present as a shock and death. That's why it's very, very important. Okay. So now you have to remember pulmonary anthrax is a Wool-Sorter's disease, and it has so many spread mechanisms, and it can cause a shock and death because of the hemorrhagic mediastinitis, widened mediastinum on the X-ray. But if you take a cutaneous presentation, that was the case scenario I gave you. Cutaneous is that you have a direct contact with an infected animal like goat hair, okay, like a goat hair. So they haven't given the animal here. You have to remember goat hair is a most commonly implicated exposure for the contraction of the anthrax. Okay, so they are going to come with painless. You should remember this word. Okay, they are going to having a painless papule. Okay, that is going to be surrounded by vesicles, exactly how they have said. So now the presentation is going to be ulcer with black Escher. So it's painless and it's necrotic. It's painless and it is necrotic. Okay, so now this can progress into death as a bacteremia, but this can progress into death as a shock. Okay, that is the two differences that you have to know with respect to the diseases. Suppose if they're asking you how to prevent your Bacillus anthrax, you have to say your AVA toxoid vaccine. So what is your AVA toxoid vaccine that is available? It is acellular. It is acellular vaccine. Okay, adsorbed. Okay, acellular vaccine that is adsorbed. It's basically available. So now how do you treat this whole condition of your Bacillus anthracis? So here they have given only your fluoroquinolones and doxycycline, but I also want you guys to remember this is prophylaxis. So what do you do after the exposure? Like to prevent the condition, we can go for fluoroquinolones and tetracyclines. Okay, doxycycline is a basic drug. But for post-exposure prophylaxis, you have to give the same antibiotics Okay, and if other therapies are not tolerated, you have to give them monoclonal antibiotics. You have to give them monoclonal antibiotics. Okay, the same antibiotics can be used as treatment antibiotics, but in a bigger dose. Okay, and you have to know that if other therapies are not tolerated by the patient, then you can go ahead with monoclonal antibiotics. So this whole concept was for the Bacillus organism, but it was an anthrax. Okay, so I told you the differentiation of Bacillus anthrax is that it is also a gram positive. Okay, like how you are seeing here, there's a gram positive rod. Bacillus anthrax is also gram positive, but you have to know it's a spore forming rod. It's a spore forming rod. Okay, so here also spores are there, but it's in a cooking rice, not your goat hair or not your patient who's having your inhalation of the spores. Okay, so not that kind of presentation. And this is going to produce your anthrax toxin. I told you they produce anthrax toxin. I told you. Okay, so now what is the differentiation between your Bacillus cereus is that Bacillus cereus, the whole presentation is food poisoning. Okay, it's called as reheated rice syndrome. That is your food poisoning case scenario. Okay, so how they will give you is they will give you a case scenario. Okay, that the patient is eating the leftover rice. Okay, so the patient is keeping the okay, you have to keep the rice warm, and when you're keeping the rice warm, what is happening is it's causing germination of your spores. It's causing your germination of your spores, and it is causing enterotoxin formation. Okay, so you have to remember, so this whole toxin that they're talking about, so what is that toxin, they will ask you. This toxin is called as your cerulite. Okay, CREULIDE. It's a preformed toxin. Okay, cerulite, you have to remember this is a preformed toxin. So the food poisoning, that is your reheated rice syndrome, it can be presented as a patient who is basically eating a leftover rice. Okay, and they are seeing that they're keeping it in the microwave, they're reheating it, everything is done, but when you're reheating it, what happens is that there is germination of the spores. So this is caused by your preformed toxin cerulite. So they have two types. One is your vomiting type, that is your emetic type. Another is diarrhea type. So with respect to vomiting type, which is basically seen with your rice and pasta, okay, so you have a emetic type and you also have a diarrheal type. Okay, emetic type is basically seen with your rice and it's seen with your pasta. Okay, like the patient is going to have all of these presentation within 1 to 5 hours. Please remember this, the time period is very important. Nausea and vomiting within 1 to 5 hours. But if it's going to be a diarrheal type, you have to remember diarrheal is going to cause a watery diarrhea or a non-bloody diarrhea. Both are almost, they're trying to meaning the same. Okay, so now they're also going to have, of course, abdominal pain, but all of this presentation is going to be seen from 8 to 18 hours. It's going to be seen from 8 to 18 hours. So you have to remember it is very similar to a E. coli, right? Because E. coli, what does it do? E. coli, we haven't come across it till now, but it's going to increase your camp. Okay, it's going to increase your camp and it's going to cause excretion of your chloride. It's going to cause excretion of your chloride and it's going to cause water loss. Okay, increase your camp, excretion of chloride and water loss. So they will ask you this as a comparison with E. coli. Okay, so now what are the terms that you have to remember with respect to your Bacillus cereus? So the Bacillus cereus is a case scenario where you're having a reheated rice syndrome, or you can understand that as a food poisoning case. Okay, so but the time duration is very important, that if you have like a patient who is coming with a reheated rice, okay, and they're having approximately, let's say, 1 to 5 hours, okay, for rice and pasta, and 8 to 18 hours, okay, 8 to 18 hours. So if that is going to be for your diarrhea type, okay, that is a two types. So because food poisoning, most of the case scenario, the presentation is just vomiting and diarrhea and abdominal pain. Okay, so the time period is very important for your division of your symptoms and organisms. So now the patient, why they're having this presentation, because of the cerulite toxin. So what is the E. coli? How is it similar? Even though they cause a diarrhea, they have an increase in CAMP and excretion of chloride, and because of that they have water loss, they have an osmotic loss. So this is how you have to differentiate your Bacillus. Okay, so now coming to the next type of organisms, that is basically your Clostridia. Okay, Clostridium, you have like three types. Okay, botulinum, tetani, and perfringens, and difficile. Okay, so now the difficile is usually seen with antibiotics. Okay, just overall I'm saying difficile, they keep giving antibiotics questions, and perfringens is going to be the one that's causing your gas gangrene and food poisoning in a late onset. Okay, and the patient of your botulinum is basically, so that preformed toxin, the same kind of canned foods. Okay, so the patients are going to be having your botulism. The disease name is botulism, and your patients of your tetani is tetanus. So let's compare each one of them. Okay, and remember the points, and then I will tell you the questions. Okay, so first, what is the difference is that Your Bacillus cereus is also gram positive. This is also gram positive. Both are spore forming only. Okay. But what we have to remember is that the tennis racket appearance. Okay. One, I want you guys to remember is that they have a tennis racket appearance, especially the tetani. Okay. And you have to remember, and one more thing is that they're obligate anaerobe roads. Okay, they're obligate anaerobes. Okay, so now let's say in the tetani, what is the virulence factor? Why are they having? So it's called as tetanospasmin. So first, what all points you have to know? First, it's an exotoxin. Okay, which is causing your tetanus. Okay, so next, where is it traveling to? It's traveling to the CNS. What kind of transport are they having? They're having a retrograde kind of transport to the CNS. Okay, retrograde axonal transport to the CNS. Okay, so now the protease is going to cleave what kind of protein? It's going to cleave your SNAD proteins. Okay, the protease is going to cleave, the protease is going to cleave your SNAD proteins. Okay, that is nothing but for the neurotransmitters. Okay, so next what you have to remember, it is going to block your release, it's going to block your release of your inhibitory, it's going to block your release of the inhibitory neurotransmitters. So what are the inhibitory neurotransmitters that you know? One is going to be GABA, another is going to be glycine. Okay, so now it's going to block the release of the inhibitory neurotransmitters. One is GABA, another is glycine. Okay, so these are from the Renshaw cells, from the Renshaw cells of the spinal cord, of the spinal cord. So these are already there in the textbook. These are the points that you have to remember for the tetanospasm. So when you think about tetani, when you think about tetanospasm as a virulence factor, you have to think that it's an exotoxin, retrograde axonal support, or a transport via the retrograde axonal transport. It's going to the CNS. It's going to have a protease. It's going to cleave your SNAP proteins. It's going to cleave your SNAP proteins for the neurotransmitters, okay, like a botulinum toxin. Okay, and one more is that it inhibits the release of the inhibitory neurotransmitter. It blocks the release of the inhibitory neurotransmitter GABA and glycine. Okay, that is from the Renshaw cells in the spinal cord. So now, because of this whole properties or the characteristic, what are we having? Okay, so let's say how is it transmitted? Okay, so now let's have a patient who's having a trauma case scenario, or have a patient who's having a puncture wound. Okay, so in both of these case scenario, what's going to happen is, even if they step on a particular nail, okay, step on a nail, or being cut because of a wire, okay, being cut because of a wire. Okay, so now all of these things, the reservoir for the bacteria is soil. Okay, the reservoir for the bacteria is soil. Okay, so this is one way of asking questions. Like they can give you any a patient's case scenario, like a patient who's having a cut with a wire, or a patient who's having like stepped on a nail, or a puncture wound, or a trauma, anything with your reservoir with related to your soil, or even somebody who went for gardening and they had a cut, okay, and they have a presentation. So the reservoir is soil. Otherwise, they can give you a case scenario of a total infant, like a patient who is having umbilical stump, okay, umbilical stump in the neonates, the colonization of the umbilical stumps. Okay, in the neonates, the case scenario is going to be colonization of the umbilical stump in the neonates. Okay, that's going to be the two transmission criteria for your tetani. Okay, so tetani, what we have to remember is they have two types. As I told you, one, they can either present as a spastic paralysis, or they can present as a neonatal tetanus. So what is the difference in the clinical presentation of both of them? What is the difference in the clinical presentation of both of them? So in your spastic paralysis, what happens is that the patients are going to be having trismus. So what is trismus? It's a locked jaw. It's a locked jaw. Okay, they have rhizus sardonicus. So what is rhizus sardonicus? You have raised eyebrows, open grin. Okay, raised eyebrows, and you have an open grin. Okay, raised eyebrows and open grin. So next is, they also have the presentation of opisthotonus. Okay, they also have the presentation of opisthotonus. And what is opisthotonus? They have spasm of the spinal extensor. So when you're thinking about spastic paralysis, when you're thinking about trismus, rhizus sardonicus, and your opisthotonus, so these are the presentation of spastic paralysis. But how will a neonatal tetanus come and present to you? So when let's say tetani spore is coming and exposure or introduction is happening to the infant, okay, generally from an unhygienic delivery or unhygienic cord care. Okay, that is what is called as a neonatal tetanus. The presentations are almost the same, but just the scenario or the situation is going to be different. Okay, so now the very major important question is that how do you prevent or treat this particular condition? The prevention of tetanus is going to be either by two things. One, you can go ahead for a toxoid vaccination, and the toxoid vaccine is like, it's going to be conjugated into a protein. Okay, the toxin is conjugated into a protein, or that's called as your killed vaccination also. So one is toxoid vaccine that you have to remember. The infants can also go for a DTaP vaccination that you basically give at 2 months of age. Okay, 2 months of age, and boosters can be given every 10 years in the adult, every 10 years in the adult. Okay, and even in the third trimester of pregnancy, just to prevent the neonatal tetanus. Okay, or even if a patient is basically having a puncture wound or a trauma. Okay, and the patient doesn't know, like they do not know about the immune status, so these are all the case scenarios where you go for a tetanus vaccination. Okay, so tetanus vaccination, what you have to remember is a toxoid vaccination. It is going to be conjugated into a protein. The toxin is conjugated to a protein. Okay, it's a killed vaccine. But for your infants, you have to remember it's going to be your DTaP vaccination that's given at 2 months of age, 2 months old, and the boosters are given every 10 years in the adults. Okay, so during the third trimester of pregnancy, you can give this particular vaccination just to prevent your neonatal tetanus, Okay, that, or you can also give it a patient whose immune status is not known, like a patient who's coming with trauma, puncture wound, step on a nail, or cut, or anything, but where the immune status is not known. So these are all the case scenarios. They will ask you these kind of case scenarios. They will ask you like whether you should give the toxin or the vaccine or not. Okay. So now the next is your treatment. How will you treat a patient of your tetanus, even though they don't ask much about that? Okay. So here we have tetanus immunoglobulin, antitoxin. So when we give this, what happens is that it's going to neutralize your toxin. Okay, it's going to neutralize the toxin. And next, you can try antibiotics. The antibiotics preferred are metronidazole. And your penicillin. Okay. So next is your diazepam. Diazepam is basically for your muscle spasms. Okay. And you can also remember wound debridement. Okay. You can also remember wound debridement. Okay. So now wound debridement is one. Okay, diazepam for the muscle spasm. Antibiotics, you have to remember metronidazole or penicillin. TIG or antitoxin is basically to neutralize a particular toxin. Okay, so that is about your tetanus. In the neonatal tetanus, I will tell you certain findings. Okay, so if they are giving you a patient's case scenario of neonatal tetanus, the usual presentation will be that babies, how will they present? They will say the difficulty in feeding, okay, and they will say that they're having a trismus, okay, and they will say that they're having a spasm, okay, they will say that they're coming with a hypertonicity, okay, they will say that the patients are having like a hypertonicity. And spasm means, how will I say in a normal term? I will say they're having clenched hands, okay, they were having clenched hands. And I will say that they're having dorsiflexed feet, okay, they're having dorsiflexed feet, okay. And I will also say or mention that they have opisthotonus. Okay, they are presented with opisthotonus. Okay, so now these are the clinical features like difficulty in feeding, your trismus or your locked jaw, your spasm and increased tone. Okay, that is presented as your clenched hands or your dorsiflexion of the foot or the opisthotonus. These are going to be the clinical features. Okay, so now with respect to the prevention, I've already told you, you have to immunize a pregnant woman and you have to go for a hygienic delivery and a cord care. Okay, so now let's move on to botulinism. So botulinum toxin, okay, like when we talk about that, it's a heat labile toxin. Okay, so it's a heat labile toxin, as I've said in the first line. Exactly same thing you have to remember. Heat labile toxin inhibiting your ACH release from the neurotransmitter or the neuromuscular junction, which is basically causing your botulism. Okay, so now even if you're going for like local Botox injections, so many patients know who want to treat your focal dystonia, or patients who want to treat your achalasia, or patients who want to treat your muscle spasms. Okay, so these are all like they have given you here the Botox toxin, the local Botox injections, where you can give it for the facial dystonia, muscle spasm, and your achalasia. So you have to remember these Botox injections is one concept that they can ask, okay, or the cosmetic reduction of the wrinkles also they can ask. So what you have to know with respect to your Botox is that it's going to inhibit the ACH release. So when it is inhibiting the ACH release, how will they come and present? They have the symptoms of descending paralysis. So I can tell you guys to remember it in an easier way. The symptoms of descending paralysis, like how they have given the Ds, you can remember that itself: diplopia, dysarthria, dysphagia, dyspnea. Okay, so now only one thing that I want you guys to remember is that in the Ds is that you have your dyspnea presentation, okay, which is basically your nicotinic blockade, blockade. Okay, so now the patient is basically coming with your diplopia, dysarthria, dysphagia, dyspnea, nicotinic blockade. So now what are the symptoms of your muscarinic blockade then? The muscarinic blockade symptoms are going to be your, for example, dry mouth, your mydriasis. Okay, so if a patient is basically coming with dry mouth, or if a patient is coming with mydriasis. So these all we can consider it's going to be a patient who's coming with a muscarinic blockade. Okay, so now this is going to be a nicotinic blockade kind of symptoms. So now descending paralysis, again, I'm repeating the patient's presentation will be descending paralysis. That is one of the major differentiation between your ascending and descending paralysis. Because if a patient is actually having a Campylobacter jejuni infection, like a patient who's having a demyelination of peripheral nervous system, which you will be studying in the neuro, they will have a ascending paralysis. Okay, so this is the descending paralysis. And one more thing you have to know is how is it transmitted. Okay, so in the babies, in the adults. Okay, in the babies and in the adults. In the babies, you have to know it's via the spore. Okay, it's via the spore. Like for example, they drink or eat honey, right? You know, mothers feed honey for the babies, so that will cause a floppy baby. That will cause a floppy baby. In the adults, what you have to remember, it's going to be via the preformed toxin. It's going to be via the preformed toxin. Okay, that is basically seen in the canned food. So what you have to remember is they will not tell you that it's a preformed toxin or it's a spore all the time, but they will tell you it's a canned food or it's a honey. Okay, so you have to look for clue words like that. Okay, so you have to look for whether it's a canned food or whether it's a honey or whether it's a reheated rice or whether the patient is actually having hamburger. So these kind of clue words are very important. Clue words are very important. Okay, so now the floppy baby syndrome in the child is seen when they are actually ingestion of your spores are taken in. Okay, so now the next is how do we go ahead with this whole presentation of botulinum? You have to treat it with the antitoxin. You just have to treat it with the antitoxin, or generally how will you treat your immunoglobulins. Okay, so now coming to the next presentation. So as you can see, the Clostridium perfringens is a case scenario where you can have the patient's presentation as your gas gangrene or your late onset food poisoning, I told you. Okay, so now I'll first discuss about the late onset food poisoning because you just studied about your Bacillus cereus, right? So in the Clostridium perfringens late onset, that is also because of the reheated rhizome. Okay, that is also because of the reheated, the patients are going to have reheated meat, okay, mainly the meat, okay, and that is going to produce your enterotoxin, okay, that is going to produce your enterotoxin, okay, but you have to remember this toxin is going to be formed only when you take like so much of quantities of Clostridial spore. Okay, so it is basically a Clostridial spore, and you have to take that in very large quantities. Then only the toxin is going to be formed. When you are eating any reheated meat dishes, you're going to have an enterotoxin, and that's only going to be formed in the intestine if you're having that spore, the Clostridial spore, in very large amounts. Okay, so when compared to the early onset, because first I want you guys to remember early onset food poisoning, I'm going to think about two options. It's either Staph aureus or I should think about Bacillus cereus. Okay, but your late onset food poisoning, you have to think about your Clostridium perfringens. Okay, the reason is because the Clostridium perfringens presentation is also going to be like a patient who's coming with transient diarrhea, the patient who's coming with transient diarrhea, and the patient who's coming with abdominal pain, the patient who's coming with abdominal pain. So that's going to be the presentation of them. Okay. So now they're also finding like new research is also saying that there is an involvement of the Clostridium perfringens in your MS. Okay. It's also involved in your MS. Okay. Which is still not like gone through the full research. Okay. But you have to remember the reheated meat dishes, the enterotoxin produced in the intestine, the toxin that is formed in large quantities of the Clostridial spore when it is ingested, which is causing your late onset food poisoning is very important. Okay, so that presentation is different from your gas gangrene. So gas gangrene, what you have to know. So any patient who's having tightness, okay, any patient who's having tightness, like a tight tissue or a skin tightness, okay, any patient who's coming with a pallor, any patient who's having a lack of bleeding, and of course, when you see this, the patients are going to have severe pain and they're having blisters and they're having necrotic tissue. So that will be the presentation of it. So now this necrotic, it looks like a bulle, right? So you can see that it looks like a bulle. So now this severe pain, blister, necrotic, bulle kind of presentation can anytime, you can have like a crepitation. Okay, you can have a crepitation. So the next kind of clues that they will give you, apart from the tightness, pallor, and the lack of bleeding, apart from the severe pain, blister, necrotic, bulle, so they will tell you that there are crepitations. Okay, they will tell you there are crepitations. They will tell you the order is foul smelling. Okay, so they will tell you there is blebs or gas bubbles. Okay, they will tell you there is blebs or gas bubbles. Okay, they will also tell about the hemodynamic instability, because the patients will have a fever and the patients will have a tachycardia. The patients will have a fever and tachycardia. So this is all the presentation of gas gangrene. Okay, so gas gangrene, why it is happening is because Clostridium perfringens, it is usually using carbohydrates for energy. Okay, so the actual fuel for the Clostridium perfringens is carbohydrates. Okay, so when it's going for a rapid metabolization, okay, in the muscle tissue, the carbohydrates, they're going to produce gas. Okay, so that's why the patients are having this bulle, the gas, the blebs, the crepitations. Okay, and the foul odor is because of necrosis. Okay, you're having a necrosis and you are having a collection of fluid, you will have a foul odor. Okay, so now the fever and tachycardia is because of the infective presentation that they're having. Okay, that is why the patients are having a hemodynamic instability. So now you have to remember the Clostridium perfringens, which feeds on your carbohydrates, that is what is staying on the muscle tissue and releasing your gas. Okay, so that is demonstrated in an x-ray or a CT scan. Okay, that can be demonstrated very beautifully in an x-ray or a CT scan. But something that I want you to guys to remember with respect to the detection of Clostridium perfringens is your Naegler's reaction. Okay, usually I don't think Naegler's reaction they would have given here in this particular concept. Okay, but I want you guys to remember this here. It's because it's a egg yolk agar. Okay, it is a egg yolk agar. Okay, and you mix it with a anti-alpha toxin. You mix it with the anti-alpha toxin on one half. Okay, this is going to, they have found when they do that, it's going to block your action of Clostridium perfringens. It's going to block your action of Clostridium perfringens alpha toxin. Okay, so, but it's not going to block the phospholipases of the other Clostridium. Okay, so now it's blocking your Clostridium perfringens, but it's not blocking the other Clostridium's phospholipases. Okay, so that was one of the detection method for your Clostridium perfringens. But when a patient is having gas gangrene, you don't have to go for a detection method. Okay, so now this is just one reaction that you can remember. It's called as Naegler's reaction, where you take the egg yolk agar, put it with the anti-alpha toxin on half, okay, which is going to block the action of Clostridium perfringens alpha toxin, because the toxin of that is alpha. Okay, so I haven't told about the virulence factor for the gas gangrene, right? So gas gangrene virulence factor is alpha toxin. Okay, it's an alpha toxin. It's basically a lecithinase, as they have said, and it's with the phospholipase activity. Okay, phospholipase C activity to be specific. Okay, so it's an alpha toxin. It's a lecithinase with a phospholipase C activity. So what is it known for? It is known to cause myonecrosis. That's what I told you just now. They sit on the muscle tissue, they eat the carbohydrates, release the gas. Okay, so now it causes myonecrosis and it also causes hemolysis. So just add one more thing, that is hemolysis to this particular. So perfringes will perforate a gangrenous leg. That's a mnemonic for it. Perfringes will perforate a gangrenous leg. Okay, so now that's why I said the Naegler's reaction, no, they will block this alpha toxin, but they will not block the phospholipases or the other Clostridium bacteria. Okay, so that is about the perfringes. And next Clostridium you have to know what the differentiation is difficile. Difficile is a very direct question. So how they will give you is any patient who is on recent antibiotics. Okay, any patient who's on recent antibiotics, any patient who is on hospitalization, any patient who's on advanced age, any patient who's on your PPI. Okay, four concepts. Okay, so you have to remember PPI is just one of them. There are so many drugs that you have to remember along with it, but you can remember them as recent antibiotics. The recent antibiotics are clindamycin, ampicillin, cephalosporin, and fluoroquinolone. They do not ask anything extra from these four. Okay, so the recent antibiotics, hospitalization, advanced age, PPI is one of the clue that they can give. Okay, and what is the pathogenesis of Clostridium difficile? So there is an intestinal overgrowth of Clostridium difficile. This overgrowth, it is going to cause a toxin formation, and the toxin is A and B. Okay, so to put it in a simpler way, what is this toxin enterotoxin A and what is this cytotoxin B? What you have to remember about it is your enterotoxin A is going to cause watery diarrhea. Cytotoxin B is going to cause cell necrosis in the colon and fibrin deposition. So I can tell you that your enterotoxin A, directly remember watery diarrhea. Cytotoxin, it's cytotoxin, so it's obviously going to cause necrosis. Where is a cell necrosis going to happen? In the colonic epithelial. Okay, in the colonic epithelial area, you're going to have a cell necrosis. Okay, so now next is they also, after the necrosis, they will have fibrin deposition also. They will also have a fibrin deposition. So now they will ask you what is a toxin mechanism, or they will ask you what is the mechanism of the patient as to why they're having a pseudomembranous colitis, because that is the name of the disease which is caused by the Clostridium difficile. Okay, so now They have two toxins. Toxin A is enterotoxin. It's going to bind to the brush border of the gut and it's going to alter the fluid secretion. Okay, when it's going and binding to the brush border, when it's going and binding to the brush border of the gut and it's altering the fluid secretion, then only you have watery diarrhea. Okay, another toxin I told you, cytotoxin, which is going to disrupt your entire cytoskeleton. Okay, which is going to disrupt your entire cytoskeleton. Okay, so they will ask you how this colonic epithelial cells, how are they going for necrosis? You have to say it is via actin depolymerization. The clue word is via actin depolymerization. Okay, so you have to remember toxin B is a cytotoxin that's going to disrupt your cytoskeleton via actin depolymerization. They're going to have all the tight junctions. They all are going to be like disrupted. Okay, that's going to lead to a cell rounding or a retraction. So this you have to remember. So when the patient is having pseudomembranous colitis, that is pseudomembranous colitis B, so this is going to be the pathogenesis of them. So what will be the clinical presentation? Clinical presentation is same. Okay, you will have the same fever, you will have the same abdominal pain, you will have the same watery diarrhea, you will have the same leukocytosis. So this is seen in a lot of case scenarios. Okay, but something that is specific you can remember for your Clostridium difficile is you have to remember that they have the pseudomembranes on sigmoidoscopy. You have the pseudomembranes that you can see it on the sigmoidoscopy. And you have to remember the characteristic presentation. One more thing is that they have toxic megacolon. That's called as your fulminant infection, toxic megacolon. Okay, toxic megacolon is nothing but your fulminant colitis. Okay, so they can have a wide range from, watery diarrhea to your fulminant colitis like toxic megacolon. So this much of variation of symptoms they can have. So how do you diagnose the Clostridium difficile? Do a PCR. PCR of the stool. Okay, you see the toxin genes in that. And how do you treat this patient? Metronidazole or vancomycin. Okay, metronidazole or vancomycin. Okay, they have only talked about the vancomycin here, vancomycin related drugs. It's vancomycin or fidaxosin. So first I'll actually talk about the difficile treatment. Okay, so for mild to moderate cases, you can just go for a oral metronidazole. Okay, so now for severe cases, you have to go for oral vancomycin. For recurrent cases, you have to go for fidaxomicin, or you have to go for fecal microbiota transplant. Basically, you take the feces from other patient and you put it as a transplant into another patient. That's called as fecal microbiota transplant. Okay, and what is this fidaxomicin? Something that you guys would not have much heard about. It's just a macrolide. Okay, so it's going to be inhibiting your sigma unit of the RNA polymerase. It's known to inhibit the sigma unit of the RNA polymerase, which is going to impair your protein synthesis, and therefore you have a cell death. Okay, so now you have to remember this. You can give it as an oral drug. Okay, so this is actually good. So these are the treatment options you have to know. That is your oral metronidazole, oral vancomycin, your fidaxomicin, and your microbiota transplant. Okay, and you have to know that your patients, if they're actually having one more case scenario I wanted to give along with the Clostridium is that, okay, so sometimes they can give you like a puffer fish ingestion. Okay, sometimes you can have a puffer fish, okay, ingestion. So because of that, it's going to cause inhibition of the sodium influx in the nerve endings. Okay, in the nerve endings, you can have inhibition of the sodium influx. Okay, so now this is actually because of your tetrodotoxin poisoning. It's called as your tetrodotoxin poisoning. Okay, so this manifestation is same thing only. Like patients have weakness, patients have paresthesias, patients are going to be having loss of reflexes. They're also going to be having the motor kind of presentation as weakness and paresthesias, like a CNS presentation. They're going to come to you like that. Okay, so that's how they usually present. Okay, so this is called as puffered fish ingestion. That's going to cause inhibition of the sodium influx into the nerve endings. Okay, so that is about all the clostridiums put up together. Okay, the other gram positive bacteria that we have majorly to discuss is basically four of them. Okay, so that will take one more class, that is your mycobacteria, tuberculosis, and all the types of mycobacteria, even your leprosy. The next bacteria we have to know is your nocardia versus your actinomyces. Okay, one is a aerobe, one is a anaerobe, so you have to know about that. And we should be learning about your Trophiderma vipellae, which is important for your malabsorption syndrome, your Listeria monocytogenes, your Corynebacterium diphtheria. Okay, so these portions are going to be discussed tomorrow. I will repeat again, entire mycobacteria related, and your entire presentation of your nocardia versus your actinomyces, and entire presentation of vipellae malabsorption presentation, and entire presentation of your Listeria and Corynebacterium. Okay, so after finishing gram positives only, I'll be entering gram negatives. Okay, and gram negatives is comparatively smaller. Okay, the teaching concepts are smaller, so I might start it tomorrow itself after finishing a 1 hour class. So because I'll be starting the class a little bit early tomorrow, we'll be having a class at 5:30. Okay, so we'll have a class at 5:30. So I'll be starting gram negatives tomorrow also, because I want to finish the theory part of gram negatives by Friday, so that Saturday, Sunday we can do questions on just bacteriology, and maybe we can include mycology. Okay. Okay. Thank you, guys.